Okay, so let's start and welcome everyone to the pediatric techna session. And so let's just get on with it. And the first talk, for the first talk, I would like to invite Dr. Abhishek to moderate and Dr. Subhadra to present. So over to you, Abhishek.
Thank you. I think we should know we are already late, and Subhadra ma'am doesn't require any introduction. She is the flag bearer of pediatric retina all over the world. And ma'am, I think we should just begin and start listening to the ma'am's talk. So ma'am is on surgical and other management challenges neonatal FEBR. So ma'am, over to you, ma'am.
Thanks to all my team who has helped me, with this work. So somebody is talking. Can you mute some mic? I don't know who's talking. Okay. So I don't know if the slide is moving forward. Let me check. Somebody is speaking.
Yeah, there is one voice in the background.
I don't know.
Rahul Jainji, I think you should just silent.
Yeah, can you please mute yourself, Rahul Jain? Mr. Rahul Jain.
Can the organizers mute? Okay. So you can see my slides, they are moving. So I think the lifelong management of FEBR has thrown a lot of challenges. As many of you would know, FEBR is a genetic disorder. It is bilateral. It always starts at birth. Actually, it starts before birth. And the hallmark is avascular periphery, and it is progressive and a lifetime disease. It has three components, the exudative part, the retinopathy, which is the new vessels, vitreous hemorrhage part, and then the vitropathy, which is the dragging and traction. And primary treatment with laser, anti-VEGF only in select cases, and cryo is done. But if there is advanced cases, then we have to look at surgical options like buccal, lens sparing vitrectomy, or advanced VR surgeries. So our data shows that because we are a pediatric center, that many of the patients who presented to us, a large majority were less than 1 year of age, and most of them present with leukocoria or nystagmus or squint or neovascular glaucoma or vitreous hemorrhage. And with older age, the number of patients who present is lesser. But the bad thing is that the younger the patient, the more severe the disease is, which is unlike other disorders where it will go from early to late. But here, the younger the patient, the more severe is the phenotype. And a lot of these patients, almost 90% of patients who present at a very early age already have detachment when they come to us. So that is the challenge. How do we manage these cases? So here is one case. You can see her right eye, she has subretinal exudates, there's a ridge, there's an avascular zone and drag retina. Now, this type of eye, we should not do only laser because there's a vitropathy and dragging. If you do only laser or cryo or anti-VEGF, it will keep on worsening the disease. So the treatment for that right eye is a surgery, whereas the left eye, where you can see there's no vitropathy, only hard exudates, even 2 or 3 hard exudates qualify for the disease. And if we have access to angiogram, it will show a lot of avascular retina. But if you don't have access to angiogram, still clinically you can make out all the avascular retina and treat that with extensive laser. So we can see all these changes. But the problem with the laser alone is, as you see in this female, 8 months after doing a surgery at a laser at 20/40 vision, massive proliferation and traction. And so you can see that vision went down from 20/40 to 2400. And if we see carefully, even at the first visit, the vessels were dragged. That shows that there was subtle macular traction there. So the avascular retina of, can we somebody mute that person? Rahul Jain? Rahul Jain, can some organizers mute him? He is talking something and he is not allowing me to talk. And you can see that the macula was already dragged. So there's always a vitropathy in this avascular retina of FEBR. So it's not just avascular retina with vitreous condensation. And the other eye of this patient, although it improved initially, but today this eye is blind of avascular glaucoma. So these patients can keep on progressing in spite of all our treatment. So the treatment for these patients usually should be vitrectomy. You can see here these exudates don't need anti-VEGF. Actually, anti-VEGF doesn't work because the VEGF itself is abnormal in these patients. There's a genetic abnormality of these cytokines. So what we need to do is to do vitrectomy. And you can see here just vitrectomy alone with laser took away all that hard exudates in this one-eyed child. So sometimes we can have very fulminant neonatal disease. It almost reminds us about APROP. So literature doesn't talk of these fulminant cases, but we have seen right on the day of birth or soon after birth, patients presenting with very severe disease, vitreous hemorrhage, retinal dysplasia. And again, these patients need immediate surgery within, very rapidly, within a week or 2 weeks, they can go into phthisis. So this is a medical emergency and surgical emergency, and we should treat them as such and operate them as quickly as possible and salvage whatever vision we can. So here's a patient, newborn baby, brought right from the labor room to us. You can see born term, and there's a neovascular glaucoma and total retinal dysplasia right at birth. So we couldn't save this eye, but the other eye had vitreous hemorrhage, and within 24 hours we could operate and save that eye. So these patients can present very severely right at birth. So in addition to this, after some years, these patients can develop a very bad detachment with rhegmatogenous, exudative, and tractional component. And these are very complicated diseases where buccal alone or vitrectomy doesn't have very good outcomes. So we've been doing scleral imbrication. I think in last Pan Ophthalmologica, I have presented that. So I'm not presenting that today. But this is how the scleral imbrication is done. We make the flaps and then we put a buccal. And you can see here that a complicated detachment like this can be treated by a single surgery. But what I wanted to show you, I hope the video is visible. Is the audio heard?
No, ma'am, we can't hear the audio.
Okay, so I will just speak. So we are doing a lens sparing vitrectomy in this case. And we are trying to go, we are not trying to create a PVD, but we are trying to go close to the fold and try to do the vitreous, traction removal as much as possible. So usually in FAVR, we'll see this fold in the macular area. This fold happens because in addition to the peripheral avascular retina, there is a persistent fetal vasculature stalk, which helps to pull it. So we just do a core vitrectomy, and after that we should do the laser. So ideally we should have intraoperative FFA and then we can do the laser. But you can see here clinically also, we should always laser behind the ridge. So good laser, not very heavy, but all the area of the avascular retina and half this diameter of the vascularized retina also, it should be done, because FFA shows that these areas in FAVR are all avascular. So behind the ridge also, it is avascular. So many times during surgery, I do LIO before starting the surgery if the media is clear. So it saves time intra-op. And then at the end, we put a bubble of air. So if the traction is very severe, then we do a nasal side vitrectomy, and sometimes we even go superiorly. So the cannula and the probes can be put at different areas. So here there was little hemorrhage, and I was concerned that there is no break. But fortunately, it was just from the edge of the vessel, avulsed vessel. Yeah, if the break happens, then the whole retina will bloat. So this is a sutureless. So when we are closing, we should move the conjunctiva from periphery towards the center. Then it will be fine. At the end, we put some, Now the other eye of this patient also had a vitreous hemorrhage. You can see. So asymmetry is very common in ROP, and it is much more common in FEVR. Mainly because of the persistent fetal vasculature stalk, which you saw in the earlier eye. In this eye, it was having vitreous hemorrhage, and we are trying to create a PVD very gently. If it comes as a PVD, we can create. So we can see here, so this was just within 3 weeks after birth. You can see these yellow dots. Now, these yellow dots look like hard exudates, but you will soon see that these yellow dots are not hard exudates. They are at the posterior hyaloid. See how they're coming? They're not hard exudates. And this is very pathognomic of FEVR. So if you have a preterm baby who shows these yellow dots, then think of FEVR. And why we want to differentiate FEVR from ROP is one, of course, it is genetic. It can be very severe at birth, as you saw. Now, when I'm removing this, there is an area of traction. As I'm creating the PVD, I had to leave alone that membrane because they started some bleeding and it was very adherent. So it's difficult to do bimanual in these cases. So ideally we could do bimanual, but that is difficult. So I just left it alone. And then I have removed that membrane after 2 years. That membrane was still there and child had grown, and then it had become mature and I could remove it easily. But at that time, our main aim is to stop the new vessels, treat the peripheral retina. And, not have any break during the surgery. So even if some membrane is left behind and we have removed all the traction around it, it is fine. We always have an opportunity to go back. So I have just left it there. And so one should remember that FEVR is a disease of arrest of angiogenesis. So most of the times the disease will involve zone 1 or zone 2. So it's very rare to get an FEVR which is involving just the periphery, just the zone 3. And so at the end, we just give dexamethasone, and this is it. So this was the surgery I wanted to show. So this is one last surgery where you can see that, whenever we see these patients, so this is an older child, so I have not put this stopper. This is about 1.5 to 2-year-old child. So here again, we can see that there is a stalk. So these stalks are the remnants of the persistent fetal vasculature, and they are the ones which start dragging the retina. So here, when we are removing the vitreous, we try not to pull on that stalk, and the stalk should be pulled very gently because it is adherent both at the disc to the retinal vessels and to the fovea. So once it is attached to the fovea, we want to trim it and not, pull it. Otherwise, we'll create a macular hole or a macular, large break. So here, my heart is stopping because it is so close to the retina, and the retina will be draped around it. So you can see here that the membrane or the vitreous, it is draped around that fovea. So you can use bimanual if you want. I'm just trying to cut it. Okay. I'm very careful that, I don't eat the fovea, and then that stalk is there. So we have relieved it. We don't try to pull it because it will be deeper into the substance of the disc, and the retina is folded around it. So we just cut it and trim it, and then the macular fold opens up to an extent depending on how closed it is. Because if we try to pull it, then we may create a break. So then, of course, we do the laser. So this, I just wanted to show the adhesion of those membranes, how we can separate it from the stalk. So sometimes we get very weird cases. So this patient, I was not sure, is this schisis? She had bilateral disease with a lot of heart exudates and abnormal vasculature. Like it was bilateral, I'll show the other eye, and is this Coats disease or FEVR? But I thought what I can do, so I just did laser around the periphery to the avascular retina, and fortunately the whole thing, you can see it just settled down. This was the right eye and this was the left eye. And then we have warned that the other family member can be affected. So her sister was born after 2 years, and she had exactly the same phenotype and the same findings. So it is a very challenging thing. So here we have another family. The first picture on your left is a proband who I saw at 7 years of age, unilateral, has a large coloboma also, and you can see a lot of extensive scarring of the laser marks. So one thing is there that FEVR doesn't have chorioretinal scarring. If you see chorioretinal scarring de novo in a FEVR case, then you should think that it is some sort of a viral torch infection. So here there is just a coloboma, and all these scars are because of the laser and cryo which has been done. And you can see that even after multiple sittings in the upper temporal area, there is still an active area which is there, this one. So, it's a lifetime disease. They will need treatment again and again, and they will develop all this fibrous tissue. But that is not the natural course of the disease. The natural course is here. You can see that this patient, we have told the sibling can get affected, and the sibling, when it was born, within 24 hours, we have gone and done the laser, and then he had persistent fetal vascular stalks, and within 6 weeks, we did the vitrectomy, and he didn't require any further treatment. Now he's almost 15 years old. So if we catch them early, then we can, change the course of the disease. So it's very important to treat them within 24 hours of birth. So here's another family, this sibling. This is a patient proband, completely blind. His cousin is also completely blind. They have LRP5 mutation. He also has osteopenia and crippling bone problems. And we have warned the family. So the day his sister was born at 36 weeks, elective delivery at 36 weeks. And you can see even at 36 weeks, day 1 of birth, she had total vitreous hemorrhage. We tried to do some laser. The vitreous hemorrhage slowly reduced. By 20 days of birth, we can now see the retina more clearly. You can see this string of pearls, yellow dots there. And you can see that there's a persistent fetal vasculature stalk, which is not allowing the retina to flatten and enlarge. So then we did the surgery and we covered this whole area. So today she's fine and she's seeing very well, has about 2200 vision. So to reduce the burden of blindness due to FEVR, we think that, early screening of these babies is required. So we should know that, the parents or siblings or cousins have FEVR, then ideally the genetic test should be done and amniocentesis done. But if that is not available in certain places, then we can electively deliver these babies at 36 to 37 weeks, and within a day or two of birth, the treatment can be done. If there's only retinopathy, then eyes will do well with laser, but they need long-term close follow-ups because they can get recurrences. But if there's vitropathy, that is, there's dragging or retina is stretched, or there's a fold, or there's a persistent fetal vasculature stop, or there's an exudation, then they don't do well unless we do an early vitrectomy. If they are combined,
I think we lost.
Yeah, I think, Abhishek, in the meantime, can you take up the discussion while we get her back?
Okay. So I just wanted to, I think ma'am gave a wonderful talk regarding the same. Can I have some opinion regarding if we have a clinically proven FEVR and then if we document that it's running in the family, so what is the role of genetic counseling for the future, future siblings? Can anybody stress on that?
Dr. Suzanne, if you would like to comment on that in the meantime while we get Dr. Subhadra back.
Like at many places we don't
as,
have. Yeah, ma'am.
As it is a genetic disease. Are you listening to me?
Yeah, ma'am.
Can you hear me?
Yeah, you are audible.
Okay, so as it is a genetic disease, I think it's very important to have a genetic typing of the family in order to be able to act soon. So the child that has this genetic trace, we should make a screening earlier in order to be able to treat the disease earlier. What do I mean? If I'm able to treat the disease in that stage where I still can do laser and stop the disease is better than when I have a macular fold. So I think it's very important when we suspect that have a fever, make the genetical counseling of all the family and the newborns of the family. So I think it's very important. And for sure, Dr. Subhadra agrees with that.
Ma'am, any role of
counseling.
Ma'am, any role of prenatal genetic, prenatal when the baby is in womb. So any role of
yes.
It will
So
be more
so the
difficult,
thing is,
but
yeah. So the thing is that somebody said if they don't have bread, why they don't eat cake? If they don't have bread, why they don't eat cake? So there are communities where genetic testing is available, and there are communities where genetic testing is not available. So if it is available, yes, it's very useful. You get the genetics of the parents done, and then you work with the fetal medicine specialist, and they do the amniocentesis at 22, 24 weeks of birth, and they will know whether the same mutation is there in that baby. And if it is there, then you deliver that baby at 35, 36 weeks, and then you treat the retina. But if that is not available, or even sometimes the genetic test may come negative because all the mutations are still not known. Only in 50% of FEVR phenotype you are able to get the test report. Then what do you do in those cases? Or the patient comes to you when they're already 8 months, 9 months pregnant, or going to deliver, they're beyond 7 months. You can't do amniocentesis at that time. So for those patients, what we recommend is we of course examine the siblings and all, try to see the phenotype of parents, and then we still deliver those babies early, with the thought that if we deliver by 37 weeks, then the risk to life is not much. And we always tell them to gain good weight so the baby is not IUGR or doesn't have breathing problems, and also the good antenatal care is important. And then you can deliver at 37 weeks where the risk to life is not very high. Most of them would be beyond 2 kg. So risk of ROP and other things would be reduced, and need for ICU care will also be reduced. And then you should examine. So our data of about 14 to 15 babies that we have now handled in this manner showed that 60% of these newborns had very severe ROP. Very severe FEVR, and we needed to treat them. And 30 to 40% had normal retina, which was a good news for the family. So that is an alternative approach which can be done where the testing is not there, or as I said, parents come late, or sometimes we do pick up this disease during ROP screening, like there's no history. But when we do ROP screening and we find that the retina is not growing, so it is arrested. So you see that it's a zone 2 retina, and then you see after 4 weeks, 6 weeks, 8 weeks, it's still a zone 2 retina. Then you start thinking that it is not ROP, it is what we call as ROPER, which means a preterm baby getting FEVR phenotypes. And of course, if the disease tempo is very different or it starts very early where we don't expect ROP, then we know that this is FEVR. So there, of course, we advise genetic testing and appropriate treatment. So I just want to highlight one thing that, I just saw a patient yesterday where 3 times anti-VEGF has been given to a 25-year-old male with one eye, and now he has developed a reg RD along with contraction of the peripheral retina. So VEGF, anti-VEGFs are usually not indicated in this disease because it is not a condition where there is high VEGF and they have abnormal VEGF. So the whole WNT signaling pathway is bad. So VEGF, anti-VEGF I only give if there's a lot of hard exudates and I have removed all the vitreous and there's no chance of contraction. So in a very limited selected cases, otherwise you need to treat the avascular retina and follow them up for the vitropathy. That is the management of this disease, not anti-VEGF like ROP.
Great. Completely agree with you, Sadhara.
Thank you, ma'am.
Anytime, have you any time tried to make a detachment of the fold in order to try to break the fold? Tell me about it.
Yes. So if it is very early and the fold is not within the stalk, so the fold happens, as I said, because of the persistent fetal vasculature stalk. In very early cases, which I showed you, all the 2 boys which I have seen within 2-3 days of birth, the fold has not closed. So there, all those cases, I was able to remove the stalk from the disc and from the fovea. And both from the disc and fovea, we have to be careful that at the disc, when we are pulling it, we should see that we are not avulsing some vessel and it's not adherent very tightly, then we should trim it. And same way at the fovea, if we think it is coming easily, then we should remove. We can peel it, or as I showed with a careful cutter. But if it is very densely adherent, it's usually like a peg. It's usually like a peg within that fovea. So it comes out. The thing is that if it is very long standing, then it may just create a hole. So we should be gentle. And usually if we trim from all around and then just at the fovea, we remove it gently, it comes out like a peg. But we should be a little careful. And we can just leave that plug there if it is showing that it is causing too much traction around and we are not able to peel. Then don't be that actively trying to remove it. Then you'll end up in a macular hole, and to treat that macular hole then becomes a difficult thing because the retina is very stretched and taut, so it may not close easily.
Ma'am, one last question regarding your first video in which you saw there was a falciform fold and with a temporal traction. Ma'am, in that case, we could have escaped just with a laser or might be scale buckling? I mean, these are.
So what I have seen is that what happens is if you try only laser, many times there's a lot of vitreous condensation there. So the amount of energy you use is very high and the laser burns don't come there because it is covered with vitreous. So we get a false sense of security that we have done good laser. But there is avascular retina behind those vitreous membranes in that fold. So we are not able to reach that. So what happens is that after some time, it starts coming back and then it contracts and then it leads to more traction and more hemorrhage, as I showed you in my initial patient.
Ma'am,
so even if you do that, you still need to follow and be ready for surgery.
Ma'am, if the same configuration was with ROP baby, would you have treated differently or you would have the same approach?
The same, unless it is a cicatricial ROP which has already healed and it is in a stable stage. Let's say baby is 3-4 years old, then we may leave it alone. But see, in ROP, the difference is that retina gets vascularized. Ultimately, the retina does get vascularized in all the preterm babies if it has not received anti-VEGF. Okay, so then it becomes stable, and especially if there's adhesion to the lens and all, then it is stable. Then it's not going to worsen. But here, the avascular retina never gets vascularized. It is a lifetime of avascularity. So it will come back with a new vessel or a traction sooner or later, or a tractional tear.
Thank you, ma'am. Thank you. It was enlightening as usual. So over to you, Dr. Common.
Yeah, so thank you, Dr. Subhadra, as usual. Very enlightening and very nice to see those videos. So I know because I've trained under her. So how amazing surgeon she is. So let's move on. And now I am very happy to welcome Dr. Suzanne from Lisbon. After completing all her training and PhD from the University of Lisbon, she has been working there and is a very well-known figure for ROP. She has participated in more than 75 extra training courses and has been responsible for editing the website of the Portuguese Society of Ophthalmology. She has been an author and co-author of several works and articles in various national and international magazines, and also author and co-author of more than 230 oral communications at various congresses. So we are very happy to have here and very eager to listen to your talk on vitrectomy for ROP. So over to you, Dr. Suzanne.
Thank you for the nice introduction, Dr. Kamal. And hello to everybody in this Sight Day, World Sight Day. It's a very pleasure to be in this meeting, speaking about vitrectomy in ROP. Can you see my screen? Is it okay?
Yes,
So,
go ahead.
Nothing in the adult surgery, vitreoretinal surgery, prepares you for the vitrectomy of ROP. So it's a unique challenge, and I'm going to give you some advices in my experience relating to this technique. So first, I advise you when you have a vitrectomy for ROP to book it for a quiet day, not a rush day with huge surgeries and all that. No, because you may need time for this kind of surgery. Then you have a tiny eye and you have to get inside that eye. That eye is different from the adult eye. It's a very tiny eye with a huge lens and usually a retinal detachment. So how do you get inside the eye? You have a lot of algorithms, but I feel that the transillumination of an almost inexistent pars plana, but you can transilluminate this pars plana, measure where you can get inside the eye, and so you can figure really where the little pars plana is and safely get inside the eye. Then you are inside the eye, okay? Now you have to decide where to put the trocars without touching the lens and without touching the retinal detachment. As you have a lot of configurations of retinal detachment, first, you must look inside the eye and see the safest place where to put the other trocars. So you put the other trocars in the places more safely, away from the retinal detachment, not to touch the retina. So if you make a hole, all the surgery is over. So you can move the trocars freely away from the places where the retinal is not detached. So you can put all the 3 trocars in one place, or nasally or temporarily, but sometimes the nasal retinal detachments are the worst. And now you are inside the eye. And the trocars are not baby trocars, are not trocars for ROP. So I have very long trocars. There is a tip to use this kind of little pieces of silicone just to put a little away from the eye, not to introduce so much trocar inside the eye in order not to touch the crystal lens. Then you are inside the eye. And this is a completely different retinal detachment for the adults, as there are embryonic structures that appear again, and they are tractional forces that we must know when we go to this kind of surgeries. So you have the anterior posterior forces that you must recognize when you are inside the eye. So these anterior posterior forces drag the retina. They can also drag the posterior retina anterior posteriorly. Then you have another force very important, that is centric forces, is ridge to ridge. So it contracts intrinsically the retina and pulls the retina to the middle, detach the retina. And finally, you have tangential forces that also must know that they can exist. And those tangential forces are more pronounced in the flat neovessels. Flat neovessels are vessels that grow between the hyaloid and the retina. And when they contract, usually associated with aggressive ROP, when they contract, you can have this typical volcano-shaped configuration. So when you get inside the eye and see this, you know that you are in a zone 1 ROP, in an aggressive ROP that detach the retina. So it's completely different configuration connected, linked to that flattening of vessels. Fourth tip, there is a quick progression of the disease. This was a baby that has a stage 4A ROP that I decided to make the surgery. The baby gets so sick, I could not have anesthesia for the baby. And 3 days later is like this, 1 week is like this, and 2 weeks is like this. So always look at the baby the day before the surgery, because sometimes the disease progresses so quickly that you can have surprises from 1 week to another week. So ROP, retinal detachment, is a pure tractional retinal detachment. What is the aim for the surgery? The aim is release the traction. So it's a retinal detachment, tractional retinal detachment, you release the tractions. That's the real aim. Of course, when you are making the surgery, you eliminate the vitreous proliferative factors. You can use in some more active disease before the surgery or not. It depends on the technique of the surgeon. Use or not anti-VEGF, because this is a disease driven by anti-VEGF, but it's, for me, a do not surgery. I just want to release traction. I cannot take the lens, touch the lens, as if I have an aphakic, it will, or a cataract, it will be an amblyopia eye. I must not touch the vessels, because if I have hemorrhages, I also can lose the eye. And the last, I must not tear the retina. It's completely different from adults. You can tear the retina in adults, then you peel all the membranes and everything is okay. Here, no. If you make a hole, almost you can say that the surgery is over. So tip, always look for the eye before the surgery, not to have surprises. And the best results in this retinal detachment connected to ROP is in stage 4A. So with the macula attached is the ideal time to make the surgery. Of course, as we are going to see in other stages of the retinal detachment of the ROP, we also can do the surgery, but the best results are in early surgery. What armamentarium can we have for vitreoretinal surgery? You can have scleral indentation. Of course, Dr. Subhadra showed the very nice results with scleral indentation in retinal detachment of fever. We can have open sky vitrectomy. I don't have experience in this, but the most experience nowadays, what we do is vitrectomy with or without lensectomy. The lens spare vitrectomy, that's why the best results are in 4A, is exactly the lens spare vitrectomy. So in 4A, all the retina, the detachment is very posterior. And what we do is we get inside the eye in 4A and we read the retinal detachment. We can see there is here the retinal detachment, and you touch after a central vitrectomy, you touch, you know what kind of vectors of forces you must cut. So you touch and you cut all over the 360 degrees, those vectors of traction. If you have doubt, you put triamcinolone. If you have doubt that you didn't cut all the vector of tractions, all the traction in the vitreous, you color the vitreous and see exactly where the tractions are. So central vitrectomy, then peripheral, addressing the vectors of traction. So this is the most important. And that's it. You don't have to make tamponade, you don't have to do anything. Just release the traction, laser of the peripheral retina, and allow the retina slowly to go to its place. And it goes nicely to its place. So this is 6 months now. The children is already 8 years old. He sees 6/10. So it's not 10/10, but he's also myope. The other eye is also myope, but sees better from this eye than from the other eye that was not vitrectomized. Now, if you have a more, most of the times the babies have platelets problems, so they bleed a lot. And this is a 4A, but it was a more severe disease. It has blood, and you see the stalk that Dr. Subhadra told. We must address this central stalk and release this central stalk in order. So it's this central stalk that connects this optic disc here and to the retina. So you must address the sentinel stalk, take all the blood, and then go to the periphery. So it's exactly the same. You go to the periphery and calmly, that's why you must have time to do all this. So you go, you cut this, then you find that you have another condensation of the vitreous, you cut the other condensation of the vitreous, sorry. At the end, it is, oh my God. At the end, let me see, laser again, and allow the retina to go to its place. Nicely, this eye, I was lucky because it was a very severe disease, but still the vision didn't gain so much like the anterior baby. So I think it was perhaps a 4B retinal detachment. This is a case of a 4B, secondary 4B retinal detachment. I was very lucky because it was me who did this big hole in the retina, but as there was a heavy laser before it became the first surgery, so I had the periphery all made laser in the periphery. I was lucky that because just for 3 months after the first surgery, I could have a complete retinal detachment of the macula. So I'm showing you this why. Before 44 weeks of age, you cannot do a PVD. It's impossible. But 8 months, at 8 months of age, like in this baby, I already could do almost like a regular surgery, like we do in the adults. So make a posterior vitreous detachment, make laser and tamponade with gas. So this is just to enhance that. The first surgery, you don't, it's almost impossible at 34 weeks of age, 40, 35, you cannot do a retinal posterior vitreous detachment, but 8 months you can already do like a surgery like in the adult. Now, stage 5. Stage 5 was what we used to call the lost stage. A few years ago, we didn't do anything to these stages. But with all the technique development that we had, and with the results, and HiCrop helped us making us a differentiation between different kinds of stage 5, we now can address stage 5 ROP with much efficacy than we did before. So without HiCrop, we can have distinguished 3 stage 5. So stage 5A, where we see the optic disc, all the retina is detached, but we see the optic disc. 5B, we don't see the optic disc and all the retina is detached, but you have a good anterior segment. And stage 5C, where you have the cornea, the crystal lens is touching the cornea already, an opaque cornea, and this is more difficult to have good results for these stages, in the surgery for these stages. So in stage 5, the best results are in stage A and then in stage B. There is already a different kind of stage 5 that is the volcano-shaped retinal detachment, is the retinal detachment connected with zone 1 aggressive ROP, and sometimes as all the retina is attached and by contraction of the flat neovessels, you have this mushroom of retina. Some people classify this as a 4B, not a 5B, but I don't argue about that. What do we do in this case? These are very difficult cases. You can do exactly the same. I mean, cutting all the peripheral vectors of forces of all the membranes in the periphery. The problem is when you address this posterior contracted retina, it's very easy to have a retinal, an hemorrhage, and it's very difficult to open this mass of retina and fibrosis. So in my hands, I still don't have the best technique to address specifically this kind of 5 retinal detachment, stage 5 retinal detachment. What I used to do is I release all the tractions and try to go there, not in the first surgery, but in the second surgery to try to open and peel the membranes and open the retina. Finally, stage 5B, it was the last stage to be addressed, but nowadays, with our techniques and new instruments, we can do it and open this closed funnel. You can do it in several ways. And I'm showing you these images because to see the stiffness of those membranes. The main objective is to release this anterior fibrosis, address the stalk, release the stalk, and release the fold, peripheral fold of the retina. What's the problem? If it bleeds, it's better that you stop the surgery and do a second surgery a little bit later, in my opinion, than do a hole in the surgery or do a big hemorrhage. So I think we can have a staged surgery. It is very active in hemorrhagically active, so we stop the surgery and then we address in a second time when the eye has a less active hemorrhage, vascularization. So the philosophy is the same. We take the lens, so we make a lensectomy, and then we address the membrane. In this case, I prefer to wait until the active vascularization of the eye is most calm. So I don't rush to make this surgery as I rush to make a 4A surgery. The objective is exactly the same. So we address the anterior membrane, release all the membrane, and we try to go as peripheral as possible to release the fold of the detached retina. So we must address the peripheral fold of the retina and now the stalk. So we must address the stalk and the peripheral fold of the retina. So as you see, you must have time to these surgeries. You cannot rush. You must still have a lot of time, spend a lot of time in this surgery. You can go by the limbos. You can go under the roof, like Dr. Hihab, under the roof of the iris. You can have full-end surgery because it's very difficult to go to this to address this peripheral fold. So sometimes, like Dr. Mohammed Tafik, that he does a surgery with 4 hands. So it's 2 hands and the other, the person that helps him making indentation of the periphery to address the peripheral fold and release the peripheral fold. As soon as you cut the central stalk, you can, the funnel opens. I left it usually or with air or with viscoelastic tamponade, temporary tamponade. And nicely, you can see that the retina goes posteriorly. This is, of course, the absorption of the subretinal liquid, but the retinal nicely can be attached in the next weeks. Of course, in this surgery, our aim is to give light perception and somehow a deambulation visual acuity for the baby. What is very important, because if you have light perception, all your hormones and all your day can be organized. So what is my take-home message? Early vitrectomy has the best visual acuity. We can do all the marvelous things with vitrectomy, with new techniques and hours of surgery, but really, when I go to a stage 5 or stage 4, something went wrong. So what I think it's most important and to enhance is we must do the correct ROP screening, and we are in the World Sight Day. So I can show you wonderful videos, but the most important is this, correct ROP screening and timely treatment. Timely treatment, avoid these late stages. Of course, we can do magics with late stages, but what we want is to protect vision. So ROP screening and timely treatment is the most important. Okay.
Thank you.
That's my message for the World Sight Day.
Thank you, Doctor. I guess the last line was the message for the day, because unless and until we do a good ROP screening, we are failing somewhere. So again, wonderful videos. And I had a list of questions for you, but then I think you answered most of them in your talk. So let me just start off with one opinion that I wanted from you. So there are two schools of thoughts when we do a ROP surgery, especially for a stage 4A, to create PVD or to not create PVD. And although I do agree with you that, it's just do as much as possible and do not try to create a PVD. But do you think there are some cases where you would want to at least try and create a PVD, or you are just happy with just relieving the tractions?
Well, when you make an early surgery, I mean, 34, 35 weeks, 36 weeks, you don't have a plan of cleavage. So it's very easy if you try to do an aggressive posterior vitreal PVD, that you can make some kind of tears or holes in the retina. And that's not the aim, because retina is elastic and plastic. So if you just, my philosophy is, if you just cut the tractions, because it's a tractional retinal detachment, it's not a rhegmatogenous. Why do you do a PVD in the adults? Because of rhegmatogenous, and posterior and the vitreous is the one with tractional. The wrong posterior vitreous is the one with traction, by making the traction. Here is a pure fractional retinal detachment. I don't say, I never try to do it. You see the second baby where there was a lot of blood.
Yes.
Blood already makes a plane of cleavage, So that baby was 38 weeks of age. In that baby, when I tried to take the stalk, to cut the stalk, suddenly I understood I could do a posterior vitreous detachment. Perhaps that's why it was a terrible case, and then it was a very nice end, but that's not the rule. The rule for me is not to induce a posterior vitreous detachment. Just release the tractions. And the least is the best. I mean, if you just release the tractions and everything is okay, I leave it. Do you understand? Yeah, and the end of the surgery, it seems that you did nothing, but you did. If you release the correct tractions, you have a good result. Suddenly you have a membrane, suddenly you have more traction, fibrosis. Then you can address in another time with a bigger eye, more safely, like you saw in 8 months of age, I could do a surgery like in the adult. So I think the philosophy is, it's a tractional, I just take the traction. I don't have PVD because I don't have epithelial pigmentary epithelium coming inside the eye. I've got fibrosis. But before, perhaps because I've got a fever also in the mixed, then I'll address a second time.
Right.
That's
So thank you.
So can I have a question?
I don't know.
Yes,
Yes.
please, ma'am.
So Dr. Susan, it's very nice presentation, actually. So I have two questions, also controversy. So you said you do laser. Do you do laser or if in all stage 4 ROP cases after vitrectomy? And the second thing is, when do you ever think of doing anti-VEGF injection before surgery if you have a very active plus disease and very active neovascularization? Or do you time the surgery related if it's already stage 4B and it's very highly active? Would you wait a bit? Okay.
Yeah, so actually I was just going to ask these questions. So yes, please.
Yeah, okay, thank you.
I think everybody has the same question. And I was going to ask the same question.
Well, first, laser. Yes, I usually do laser, because most of the 4A surgery are in a very, how can I say, you have a huge avascular area. You want to be sure that the retina will stay in the correct place. And there are the two motives. So you stop what motive this disease. So the retina that is avascular, don't you forget you are making a surgery in a very tiny baby. So I usually do this. So I do laser for two motives: to try to maintain the retina really in the same place and to avoid the going on of the disease, because the baby is very, very, very tiny baby. Sometimes this is an ongoing disease. I mean, the laser is already there, but I think it's more safe to do laser at the same time. And there is sometimes it's very difficult to make laser, indoor laser, and you can do it before the surgery already with the baby sleeping. I don't do it, I do inside, but usually for these two motives, I do laser. The second question was anti-VEGF. Well,
Yes.
when you make the surgery in a very tiny baby with a very active disease, you don't want it to bleed. So you don't want blood inside the eye after the surgery, during the surgery. And if it's a very active disease, yes, I do anti-VEGF before the surgery. What's the problem?
How long
As
before?
you live, you have more problems. What's the problem? You have a very active disease, you have flat neovasals, you make the anti-VEGF, and suddenly the baby has a sepsis in the same day. And you cannot make the surgery that day, you cannot make surgery in the other day. And suddenly, next week is a crunch disease. You can make the surgery, but it's very much more difficult because fibrocytosis now is fibroblasts, now are fibrocytes. And the result is not so good. So if the baby is a very active disease, I still do anti-VEGF, but I do just 24 hours before, because in 24 hours it's very difficult that the baby suddenly you cannot make the surgery. And 24 hours is what is enough to make disappear those little hemorrhagic vessels, that still don't have. Those are the vessels that bleed, are the new vessels, very sensitive to anti-VEGF. So I do it in those very active eyes, but always with my heart like this, suddenly I can have a problem and the baby cannot have surgery, and then we can have a crunch phenomenon. What it can happen. So when you do anti-VEGF before, hold your mind, you must be aware of this problem, but it helps you in these very active vessels. It helps you.
Thank you, Dr. Suzanne.
So it's always good and bad. You do it, but you must know what you face.
Yes.
Thank you so much for all the comments. And I'm sure there are a lot of more questions, but we are really running short of time and we would want to move on to the next talk.
Thank you. Thank you.
Yeah. Thank you so much.
That was so nice. Very nice. Thank you.
So now I would like to invite my personal favorite, Dr. Divya Balakrishnan. And again, as somebody who has trained me, I know that she has been a fellow favorite. So she's a former faculty from Delhi Prasad Eye Institute and now is working in Kerala. Dr. Divya, if you can please share your presentation. And it's wonderful to have her here. And we would want her to speak on retinoschisis. We can't see your slides yet, Dr. Divya. And Abhishek, can you mute yourself, please?
Okay.
Still not visible, Dr. Divya. Any issues? Can't hear you as well. Okay, so while we sort this out, I would want to move on to the next speaker. I would invite Dr. Sushma to moderate her talk, and I would very fondly invite Dr. Mariam for her talk.
Hello, everyone. Happy World Sight Day. I'll be inviting Dr. Mariam Al-Fiqi from Cairo, Egypt, and she is a vitreoretina and pediatric retina faculty at Al Sham University. And she is known for her good work in pediatric retina and ROP. And she has published her work in multiple peer-reviewed international and national journals. Dr. Alfiki, welcome, and please take over.
Thank you so much for the invitation, and I'll be sharing my presentation now. So just a second. So can you see my slides?
Yes, Dr. Alfiki, you can just.
Okay.
Yes.
So yes. So I will be talking about persistent fetal vasculature. How does it happen? It's actually having several patterns of inheritance, either sporadically, autosomal recessive, or autosomal dominant. And what happens in PFV? Can you see the cursor? This cursor, can you see it? Yes, I'm moving with it.
Yes, we can.
Yes, okay. So we have here the hyaloidal system in the secondary vitreous, and it has to involute before the delivery, but it does not involute. So whatever remains of it will cause the persistent fetal vasculature. That's why it has a diverse pattern of presentation. It can be an anterior form, a posterior form, a combined form, and it can be associated with other pathologies, as we saw in the previous presentations. So what about the anterior form? Anterior form can be very mild, like the Mittendorf dot, which we should only follow up, or it can be more severe, like the posterior polar cataract, or it can be like a dense cataract with this band extending from the posterior pool of the retina up to the anterior segment, but it does not affect any part of the retina, just a band, either vascular or occluded and being like a fibrous band. It can be associated with microphthalmia, and the fundus, as we said, is normal. So when we have posterior polar or dense cataract, how we manage? We remove the cataract from an anterior capsular excess, and then you have to cauterize those blood vessels, or they will bleed, and you will end with a vitreous hemorrhage. So whatever you see on the posterior capsule, you cauterize it, and then we open the capsule, as we see here. And then you have to go with the diathermy probe and cauterize the blood vessel at the back surface of the capsule, because usually it is vascularized from the optic nerve up to the anterior segment. As you can see here, I cauterized this part, it regressed posterior, but the residual part is still vascular. You don't have to go posterior to get the whole band from the up to the optic nerve. You just have to cauterize the anterior part of it and then leave it to throw down and make your posterior capsular excess and close the surgery, either you implant or not, according to the age of the child and if the anterior segment is big enough to have an implantation. There is a more severe form of the anterior persistent fetal vasculature where you have this dense retrolental vascularized membrane, and you have dragging of the ciliary processes, and you have a microphthalmia, anterior and posterior microphthalmia in those cases. Usually we don't implant early. This is something very important. You don't have enough space in the anterior segment to implant if you're working like at 4 months or 6 months of age, or even at 1 year. It's usually microphthalmic. And again, in the B scan, I just have strands extending from the optic nerve up to the anterior segment, but you will see when we open this band, how do we do the surgery? We do remove the lens, and we remove the capsule of the lens, actually, because the capsule is redundant. It will not take an IOL. If you want to implant, you will implant on the residual parts of this membrane. Then we do a cauterization to the vascular network of the membrane and make an opening with an MVR plate. Those membranes are very thick. This is an anterior segment OCT. You can see I removed half of the membrane and still I have a residual thick part of the membrane. And then this is the final picture after we make an initial opening. I usually go in those cases and check the fundus, cauterize the band extending from the optic nerve up to the anterior segment, as you can see, and trim it. And I will show you something why you should not enter in those cases through a pars plana approach. Usually when you have an anterior form PFV like this, you can have this anterior traction of the retina. So if you go through the pars plana, you are going through the retina and you will end with a retinal detachment, not just removing the membrane. So finally, we make radial cuts because those membranes can regrow again. We make multiple radial cuts. One of them has to be passing between the ciliary processes, like this one here. I'm trying to go in between the ciliary processes. And because this child was actually 2.5 years old when I operated on him, so the eye was already big to implant, but usually when you operate earlier, the eye is small and you cannot put an IOL in the sulcs. You have to wait. If the eye grows, you can implant. If not, you just fit them with the aphakic glasses or the contact lens. This is another picture of the anterior form. You can have the lens very much swollen like this and pushing the iris and everything anterior, and you can have the lens much shrunken like this, and the AC is very deep, so it has different patterns and all of them are managed the same. You remove the lens with the capsule and you tackle the membrane as we said before. What about the combined form? When you have a cataract like this, and when you do the B scan, you find this thick band. This is not a closed funnel retinal detachment. You have this very pathognomonic picture in the B scan, the food processes you can see here. And when I do fundus examination, I usually like to do fundus examination if I can through the clear area of the lens, and I can see the retina is flat here and I have a fold. So I know this is not a closed funnel retinal detachment. This is a PFV band extending up to the lens. Again, removing the cataract and then doing cauterization to the stump. And I'm not trying to touch the fold because I know this is whole retina is attached to the back surface of the capsule. I'm trying to make a wide opening in the posterior capsule, a posterior capsular access with a scissor. And you will see now I will do self-indentation to get this peripheral part. Self-indentation is actually more controllable in surgery, in the posterior segment surgery in general. So I go with the self-indentation, trying to get the capsule with the scissor until it is completely free. And then I want to see the posterior segment, because in PFV, you have to relieve the stalk from the vitreous, which is surrounding it, to allow it to settle down posteriorly. So this is what I'm doing. And there was a controversy if I have to implant in this child or not, because this is unilateral and this is an amblyopic eye. And so I said, if I can implant, I will implant. I don't have a problem with implantation. The eye is good. And I did him a very deep amblyopia treatment. And this is a picture of the child 8 months later. I have a disc. This is actually the macula. Yes, it is corrugated, but you will be surprised that the child can actually follow and fixate objects now, and he even can count fingers. So I think those children can do very well with amblyopia therapy, even if it is very unilateral. There is another pattern of the combined form where you have the retina actually dystrophic. This is my opinion. Usually in those cases, I don't take the hassle of an IOL implantation because I don't think they will benefit with a very much dystrophic retina as this pattern. What about the strictly posterior? You can either have just a band extending to the back surface of the capsule. You can see it here. So I just go trimming around again the band, which is dragging the retina anterior, and trying to cut with the scissor the attachment of this band to the posterior capsule of the lens. Actually, the lens is clear. It is just attached to the posterior capsule of the lens, so I don't have to remove the lens in those cases. I keep cutting as much as I can. I don't like to make a cut in the posterior capsule. So even if there is a faint residual part of the capsule of this band attached to the posterior capsule of the lens, I leave it. I do inject triamcinolone, as Dr. Susan said before. If you want to see the traction, put triamcinolone, you will see the residual parts. Although you can see this at the end of the surgery, I also put Helon. I want to keep the tension well formed in those children. You can see here the posterior capsule. There's a very faint opacity. It is not significant. And the retina much regressed posterior. And this child with the glasses fitted, she can follow and fixate objects very well. You can have another pattern. The lens is completely clear, but the band is there in the mid-vitreous. It is staying in the mid-vitreous. So again, we go through a pars plana approach. You do trim the anteroposterior attachment of this band to the lens. Take care if there are any vessels still active. You have to go very much away from them or they will bleed hell, and this can end your surgery. Even on table, it can go well, and post-operative, you have extensive bleeding. So if you have any blood vessels active, go away from them and cut the band. And then I go trim 360 degrees around the retinal fold, whatever its shape, until I make sure that the fold is completely free, and again inject Helon. This is another very peculiar pattern where I have extensive, as you can see, I got out with the infusion. I have hemorrhage. I did not touch anything. This hemorrhage is behind the capsule. So I'm now cauterizing the blood vessels that are on the posterior capsule of the lens. And I'm making an opening in the posterior capsule, trying to remove this vitreous hemorrhage. So this is a very specific entity. I just saw it in a couple of presentations, and this was my only case actually, where you have those twigs attached from the posterior capsule of the lens, and they are pigmented. And you will see now when I'm doing the indentation, I'm cauterizing the central blood vessels that was bleeding here. But you'll now see the twigs I'm talking about. Those twigs, they are extending from the posterior capsule, and they are sending back to the back surface of the retina. Actually, those twigs, if you leave them after a while, they will contract and they will cause some traction on the retina. So it's better you trim them either anterior or posterior, not to leave them attached to the retinal surface. At the end of the surgery, I tried to do some radial cuts in between the areas where I could not remove, so that when the capsule contracts, it will not cause like a capsular phimosis and drag the whole peripheral parts of the retina. There is another pattern where you have like, yes, I have here a area of fibrosis in the posterior part of the lens capsule, but this part is attached to the periphery of the retina. The central part and all the rest of the retina is okay, so you don't have to operate in those cases. Sometimes they have a posterior lenticonus from the dragging, and then you have to fit them with a myopic glasses, and they do well. The most severe form actually of PFV is the picture, which is like a stage 5 ROP cases. You have a highly distorted retina, everything is dragged anterior, and there is this part of PFV. You cannot open it. It's not like the central stalk in ROP cases. If you go in between those folds, you can go and dissect this band. But in PFV cases, you cannot dissect this band. It's very difficult and it's highly vascular. This is the main difference between them, also the history of prematurity. So I act like RP cases. I dissect the membranes from the surface of the retina until the retina is completely free, like this picture. And this is a picture of the case several months later. So I work on them actually when they are bilateral. If it is unilateral and the other eye is completely normal, I would not operate. This is a last thing I would like to say, the cases associated with arthropathologists. So this is something I'm recently describing. I saw in several premature babies. That was one of the most obvious cases, a case presenting with this aggressive retinopathy of prematurity picture, as you can see, and the central retina is detached. And when I do the vascular loops, a picture of AROP, and when I make an anterior defocus, I have this band of a PFV. It is actually attached to the posterior capsule of the lens, and it is vascularized. Again, I have the same picture in the other eye, an extensive avascular retina, vascular loops, central retinal detachment, new vessels extensive over the detached retina, and with anterior defocus, I have this PFV band. So that was a case of bilateral aggressive ROP, central retina is detached, he's just 1.5 months old, and he has this PFV band, highly vascular. So even if I want to operate, I will have an extensive hemorrhage later on. So I decided to do an intravitreal injection of anti-VEGF as a preparation, and waiting for those new vessels to regress. They are not regressing, they are highly active, and they are back to the back surface of the lens. So I cannot go like trim around the detached retina and leave this central stalk. This would not be fine. So I have to wait. I kept waiting until that was the picture of the left eye. Again, that was the picture of the right eye. And I waited like 1 month, and I thought I had that retina totally corrugated over itself in the center. So I lost the eye, but I said, okay, I would go and manage as a PFV case. So again, through a pars plana approach, I am removing the vitreous 360 degrees around the PFV band, and I think it will act like PFV cases, and I will have this central part of the band regress posterior after the surgery. Can you see the loop of the AROP still there? And I'm trimming the vitreous. I use actually the cutter to see the band as we move here. You can see the band here is still there. So I use the cutter to see where is the residual vitreous while I'm going around the central detached retina. And I keep doing this until I have the fold completely free. And to my surprise, after 3 months, I can see a disc and I can see a flat macular area. That was the left eye. And again, that was the picture, sorry, that was the right eye. That was a picture of the left eye. And that child came to me 5 months later after the surgery, and he can follow and fixate objects. So how many times I saw this picture? It's like I have 5 cases now after several years. They are very peculiar. I don't know it's related to prematurity that we have an associated PFV band highly active. So my take-home message is that PFV has different patterns. You have always to rule out, in cases of congenital cataract, if you have microphthalmia by B-scan, you have to rule out if you have PFV. If retina is detached, you still have a chance, especially if it's not dystrophic. And PFV can happen unilateral, and that has been reported in Egypt, and it is written in OMIM that they have several families with bilateral PFV, and PFV can be combined with other pathologies like ROP. Thank you.
Thank you, Dr. Alfiki, for that beautiful talk and excellent compilation of surgical videos and pictures. So,
thank you so much.
as you rightly mentioned, it's very important to rule out the unilateral causes of leukocoria, in which one of the common cause is PHPV. So just a couple of questions, quick, keeping time in mind. So one of the most common complications which we see is glaucoma, especially when you implant IOLs. So how will you go about in managing that? And will you consider IOLs in all cases, especially they'll have microphthalmia, microcornea. So how will you select cases, and how do you manage the post-op glaucoma and follow-up of such cases?
So usually in children, if we are taking about PFV, because it's usually unilateral, so I would not implant before 1 year anyway. If they are presenting early, I'm doing the surgery at 3 months. I wait for the surgery till 3 months old. If the retina is okay, I don't operate before 3 months. This decreases the risk of glaucoma. And when I go for the surgery, I would not implant early. I wait till the age of 1 year. And at the age of 1 year, I measure the anterior segment, again, the white distance and the corneal diameter. And if I still have a small anterior segment, I do not implant. I wait up to 2 years or 3 years. And especially if they are fitting with, we have here several companies doing ultra thin phakic glasses. With the ultra thin phakic glasses, the children can do very well, actually. So if they are doing well with the glasses, I don't rush for the implantation anyway. If I have a good anterior segment, I would implant. Otherwise, they can go with the phakic glasses, and they do well with the amblyopia treatment.
So another quick question is that since I was under Dr. SJ, how often you have seen, we had a cluster of cases where there was a bleed in the Berger space. So it was not a leukocoria which the baby presented with, but it was more of a red blood reflex. So have you seen such cases where hemorrhage, especially in the anterior segment, which presents where you go inside and see it as a PHPV, which SJ calls it as a poppy PHV. We are still struggling to publish it. So yeah.
So no, in the anterior segment, no, but I have several cases with vitreous hemorrhage, presenting with vitreous hemorrhage, extensive, even at birth. So I had that case presenting 1 week post-operative, and it's a bilateral retinal detachment and vitreous hemorrhage, and it was PFV case.
Yes. Thank you. Thank you. Dr.
Thank you so much.
Yes, yes, sure, Dr. Jalali. Yes.
Really very good cases and very challenging ones. Just few points that initially I was not operating these cases, but once I shifted completely to pediatric retina and stopped doing adults, the confidence and the understanding of the pathologies really improves. So I think, being a pediatric retina surgeon full-fledged really helps us to improve our skills and get more confidence. So when I do some of my colleagues do the anti-segment surgery, most of the times I have found that it's not really essential to cauterize the vessels in the membrane or the plaque, except for the stalk on the disc. Because once we cut the thing and raise the bottle, all these vessels retract and they don't bleed from the capsule. So usually, because I'm concerned about doing cautery in the anti-segment, it will damage the endothelium. So mostly it's not really necessary to cauterize. Once we remove all the membrane, it doesn't bleed. It will just stop very shortly. The second thing is that, this glaucoma will usually be seen, especially when there is a peripheral anterior to begin with. So it's important before you start to do a gonioscopy in these eyes. That really helps us not only for PFB, but for other cases also. If we are able to do a copy-lens gonioscopy pre-surgery, then we can see that, some parts of the angle are closed and those children would be more at risk. You can still treat them, but you can, tell the families that there's more risk of glaucoma, especially angle closure glaucoma, because they already have some compromise of the angle. That's a good test to do before surgery. And the last I wanted to say is that, some of the times then when we are going near the stalk, we have to be very careful because the retina may be draped up into the stalk. So you can differentiate where the stalk is and where the retina is by keeping the bottle low and seeing the vessels, and then cut only the stalk and not the retina. And PFV, you nicely showed it can be part of ROP, it can also be part of Coats disease, it can also be part of FEBR, as I showed. So that changes the configuration of the retina, and we should be aware of that stalk. If there's a stalk, the disease will worsen faster and the retinal detachment will worsen faster. So our intervention should be earlier. That's what Susan also showed, and you also showed those volcano detachments. Wherever there's an adhesion to the lens, always do surgery earlier rather than late. They will always worsen.
Thank you, ma'am. Thank you.
Thank you, Dr. Subhadra, and thank you, Dr. Mariam, for those wonderful videos. We would move to our final talk with Dr. Divya again. Dr. Divya, if you are ready.
Thank you, Komal. So my talk is on surgical challenges in congenital X-linked retinoschisis. So as we all know, X-linked juvenile retinoschisis is one of the leading cause of macular degeneration in male. Can you see the screen? Yeah.
Yes,
so
ma'am.
there is a mutation in the RS1 gene which encodes retinoschisin, the deficiency of which results in splitting of the retinal layers. So the main clinical features, the characteristic feature is the foveal radial spokes, which result from the foveal schisis, and 50% of them can have peripheral retinoschisis and associated inner breaks with free floating or the bridging retinal vessels. They can develop outer retinal breaks too. So the surgery is indicated when these children develop the complications because of this disease, which is retinal detachment. This occurs when they develop breaks in both the inner and outer retinal layers. And these free floating retinal vessels can lead to recurrent vitreous hemorrhage. And when there is a non-resolving vitreous hemorrhage, again, it is an indication for surgery. So this case one is a 4-year-old boy who was brought by parents with a sudden decrease in vision following a history of fall. The child was uncooperative for detailed evaluation, but a dilated fundus examination, we could see a vitreous hemorrhage in the right eye. Left eye, some RPE changes, but a detailed evaluation could not be done. A B scan was done, which showed a high reflective membrane with moderate reflective submembranous dot echoes. So a diagnosis of vitreous hemorrhage was done, and the child was posted for surgery. And an examination under anesthesia for the left eye. So this is a surgical video. So we noticed that there was vitreous hemorrhage. As I induced the PVD, I noticed there was breaks inferior to the disc. And so I thought initially that I had induced a break there, but as I extended the PVD, I could see that there were large breaks inferiorly. These were some of the initial cases. Then I realized I'm dealing with the case of retinoschisis with vitreous hemorrhage. So I tried to induce the PVD over the inner retinal layer wall as far as possible, and the peripheral vitreous was shaped. So here you can see that the major inferior arcade vessel was avulsed, and the large inner retinal breaks, and the peripheral inner retinal wall is left behind. So the vitreous hemorrhage was removed, and after completing the vitrectomy, endolaser was done at the edge of the retinoschisis and to the outer retinal areas of thinning. So this is a post-op picture where you can see that the avulsed inferior arcade vessel, the retina is attached, and the child was having a vision of 20 by 125. And this is a fundus picture of the left eye, which shows the RPE changes. The second case was a 7-year-old boy who was brought with complaints of deviation of eye, and his best corrected visual acuity was 6/60 with +6 in right eye and counting finger 3 meter in the left eye. So this was the fundus picture. You can see the retinoschisis involving the inferior and temporal quadrant extending up to the fovea, and which is like seen very nicely in the OCT, where you can see the inner retinal layer extending up to the fovea. So this is the picture of the left eye, where you can see the RD involving almost all the quadrant except the supranasal. And the OCT actually confirms the RD extending up to the fovea and nasally. Surprisingly, once the retina is detached, I did not find much of a schisis changes in this retinal layer. So this is a video of the second child. So PVD could be easily induced in this case. And the PVD was extended to the periphery. With the periphery, the vitreous was shaved. As I went temporarily, the inner sciatic wall was very thin and vitreous was very adherent. So I could not remove the vitreous of the inner retinal layer. So I removed the inner retinal layer along with the posterior hyaloid, but no definite break could be identified. So I decided to make a retinotomy in the thinner outer retinal layer. You can see the subretinal fluid escaping. Fluid air exchange was done. And I did endolaser around the retinotomy. You can see that nice laser burn uptake, but posteriorly the laser burns were not coming. So there was some residual subretinal fluid posteriorly. So another retinotomy was made, again in an area where of a suspected outer retinal break, to ensure complete drainage of the subretinal fluid, so as to do laser around all the suspected outer retinal break area. So this is a post-op picture. The patient is due for silicone oil removal. You can see that nicely the retina is attached, and the child is having a best corrected visual acuity of 6/60 in that eye. The next case is a 6-year-old boy who was brought with again sudden decrease in vision, and this is a fundus picture of the right eye. You can see the RP changes at the macula, and the periphery you can see the dendriform vessels which are there in the periphery. And so this child had retinal detachment involving the superior and temporal retina. In this case, triamcinolone was used to induce the PVD. And I could see that there was a supratemporal HST, shooter, which was there. So I tried to remove the subretinal fluid through the same superior braid, but I did not remove the inner layer in this case. So fluid air exchange was done. You can see that nice laser burn uptake in the periphery, which confirms that the peripheral retina is attached. So in these cases, actually, you may not get any burns. If there is a posterior, here you can again see that the burns are not coming posteriorly. You can see multiple thin outer retinal holes. So again, I made a retinotomy in the inner layer corresponding to the area of the outer retinal thinning to ensure complete drainage of the subretinal fluid. So once the subretinal fluid is drained completely, you can see now nice laser burn uptake. So if you have not removed the inner layer, you will still see that the inner layer might appear little lifted, but don't bother about that. If you get nice laser burns, it ensures that the outer retina and the break is attached over to the RP. And this is important to make sure that all the suspected outer retinal thinning and the breaks are covered. So this is a poster picture. This is after a silicone oil removal. And you can see that even though I have not removed the inner layer, after the surgery, that schisis had collapsed actually, and the fovea still shows the foveal schisis. So this was another 13-year-old baby who was brought again with the deviation of the eye. The child had vitreous hemorrhage in the right eye, which was like old vitreous hemorrhage, and the left eye had schisis extending up to the fovea with streaks of vitreous hemorrhage. So after core vitrectomy and completing the vitrectomy, I could see some membrane-like structure which is posterior. So initially I thought that was the layer of thickened posterior hyaloid. As I dissected, I could see that that was the totally suppression of the inner retinal layer in space. Then I decided, because it was a complete retinoschisis causing a suppression of the entire inner layer, I cauterized the vessels and removed the entire inner side. And laser was done nasally along the traction area where there was a suspicious break. So I was not expecting much of a vision in this child because it was a total schisis. And this was a video sent by father of the child. So the better eye is like kind of patched, but I was happy to see that the child was able to pick up these eatables and was eating. So hopefully the child will get some useful vision in this eye too. So in retinose cases, the surgery is challenging because to start with diagnosing it, especially when the child present with vitreous hemorrhage, and trauma may be always a misleading history. So we have to analyze the B scan carefully and examine the other eye for clues of any other underlying congenital disorder. And these rolled out edges in the outer retina actually gives us a clue to locate the location of the outer retinal breaks. And while placing the surgical, during the surgery, while placing the cannula, sometimes you might see that, especially in very young children, the inner sciatic wall may be so bullous that you might see the inner layer just beneath the lens. So in those cases, you have to be very careful while placing the cannula. Maybe the cannula can be placed nasally. And triamcinolone is always a helpful tool to assist in vitrectomy and PVD induction. And if the vitreous cannot be removed from the inner sciatic layer, then you can remove the inner layer. The aim is to flatten the outer retinal hole and the layer with the RP, and the inner layer may not flatten always. And actually the laser burn uptake in the outer layer gives us a clue if the retina is completely attached. And I usually make a retinotomy corresponding to that area of the outer area of retinal thinning or the break to ensure the complete drainage of the subretinal fluid. And the final outcome depends upon the macula changes. And most of these children may have a visual acuity between 20 by 100 to 20 by 400. And I acknowledge Dr. Subhadra, who is my mentor in pediatric retina. And thank you.
Thank you, Dr. Divya, for all those wonderful videos. Again, I had a lot of questions, but I guess the first one that I would want to ask is about the case that you showed where the OCT actually showed a detachment but did not have much sciatic changes. So I recently operated a case which was very, very similar to that, absolutely similar OCT. And again, when I went inside the eye, I really could not find a particular break either in the inner layer or the outer layer. Again, not very, because it was not very sciatic. It was not a very proper retinoschisis that I could find when I went inside the eye. So any particular tips on cases like that where you have schisis in one eye and the other eye has a detachment, and you suspect that it is actually a retinoschisis related detachment, to find out those small retinal holes that might be hiding somewhere?
See, most of the time, that's what I mentioned. In many cases, it is very difficult to locate the cause for the primary break, which causes the retinal detachment. Sometimes you can have these kind of tractional break. In that case, you can see that there was some superior tractional HST was there. And another clue is that many a times you will see that these outer breaks are little more white, like with the rolled out edges, if you look very carefully. But that is evident only if the break is slightly large. Very small breaks, it is very difficult to identify these breaks. That's the reason, like, I always, initially, I never used to do these extensive lasers. But nowadays, after operating quite a good number of these cases, I realized, because it is very difficult to locate these specific breaks. So you make a retinotomy in case if you are not able to get these posterior laser marks. So I make a retinotomy in those areas of suspected outer retinal thinning or the suspected break, and ensure complete drainage of the subretinal fluid, and do laser around those areas, all suspected areas.
Right. Thank you for that. And again, your opinion on the controversy of whether the inner leaf should be removed or left. How do you decide on that?
See, in the second case, which I showed, the first case, actually, the inner layer was very thin and the vitreous was very adherent. So if I'm sure that I'm not able to remove the vitreous, or I'm not able to remove that, then I do remove the inner sciatic layer. In the second case, I found that the inner layer was actually pretty thick, and I could nicely peel the vitreous above the of the inner layer. So then I did not remove that inner layer. So in case if you can remove the vitreous nicely off that, then I don't usually remove the inner sciatic layer.
Okay, and then in these cases, you do a laser all around the sciatic area?
Yes, I do.
Okay, so thank you
So,
everyone. Thank you, Dr.
Can I have a question, please?
Yes, please go ahead.
Okay, so thank you for a very nice presentation. So when you leave the inner sciatic layer, do you laser the whole layer, or you just laser around the retinotomies? And I have a second question. Did you ever try doing a buckle on those cases, if you can think where the break is?
In retinose cases, sometimes I do support these cases with the buckle, but I don't just do a buckle and let it go, because I always feel vitreous has something to do with pulling off these inner sciatic layer. So I always combine a vitrectomy with a peripheral belt buckle. I've not done a pure scleral buckle in many of these cases.
So because I tried this and it worked, a pure buckle, but it takes a very long duration for the subretinal fluid to go, because it's usually here for a while. So when you do leave the inner leaflet in the vitrectomy, do you laser the whole inner leaflet or just the retinotomy?
No, I do laser all retinotomy plus all these suspicious outer retinal areas, thinning or any outer retinal breaks. But as I mentioned, you don't see that inner retinal layer settling during even intraop also, because it doesn't get attached to the outer retina as such.
Yes.
So it will always give an appearance that it's lifted up. So even in the post-op, even if you do silicone oil removal, you will see that inner layer, if you have left it, it might be slightly lifted up. But in this case, which I showed, actually, surprisingly, I saw that the wall had collapsed, even though I had not removed it.
Okay. So my last question is about vitreous hemorrhage in those cases. Do you operate as soon as you see the vitreous hemorrhage, or you wait for a little bit? It may resolve spontaneously.
No, if it is a very small hemorrhage, and I don't operate as soon as I see the vitreous hemorrhage. So I give them a chance for the spontaneous resolution, and if it doesn't resolve or the child comes with a recurrent vitreous hemorrhage, then only I go inside.
Yes, thank you so much.
Okay, thank you everyone for such a wonderful discussion, and thank you for all our guest speakers. Very, very nice and a very, very useful discussion, but we are really running late, and the next session is about to start. So again, thank you everyone, and I hand over to the next moderator for the next session.
Thank you everyone. So much. Thank you. Thank you.
Great talk. Everyone. Okay, bye.
Very good evening, everyone. We've had a very interesting pediatric retina session, and now we move on to tackling trauma. Trauma, as we all know, is one of the most unpredictable surgeries that we have. And without wasting any further time, I will directly go to the first speaker. Dr. Aditya, can you please introduce Dr. Sangeet?
Yeah. Hello, hi. A very warm good evening, everyone. It's my pleasure, my honor, and my privilege to welcome and introduce Dr. Sangeet Mittal to everyone. He is the Director of VR Services at Thendai Hospital, Jalandhar, Punjab, and he has done his MS Ophthalmology from PGI, and then subsequently joined the VR Surgery Fellowship from the prestigious Shankaraya Netralaya. Now coming to the academics part, he has won numerous laurels in national and in international meets. And he has also won Best of Show award for 3 consecutive years at EVRS. Now coming to the local conferences, he has just now been awarded as the Ophthalmology Star of India during its annual conference in February 2020. Now let's just welcome the Dr. Sangeet Mittal, and I'm sure this talk will be a pretty enriching one. Please, sir.
Thanks, Aditya, for all these kind words. So I think we are already running late, so I'll just get on with my presentation. Can I share my screen now?
Yes,
Yeah.
My screen visible?
yes, sir, it's visible.
It's
Okay.
visible now.
So the topic which was given to me for today's presentation is chorioretinectomies to the rescue for deep impact ocular trauma. So what is the chorioretinectomies were introduced as a therapeutic procedure in 1987 by the great Dr. Zivozanovic, and it was used as a prophylactic procedure by Dr. Ferenc Kuhn in 2004. It is for deep impact ocular trauma with its incarceration and the penetration of choroid. And it is supposed to reduce the RP proliferation, fibrous ingrowth, and PBR from the wound side. And as I said, it could be done as a prophylactic or a therapeutic procedure. And how do we do it? First, transinolone assisted vitrectomy with or without which face shaving is done, depending on the case. Then deep, that is 100% endodiathermy burns are given around the incarceration site. A removal of the incarcerated retinal tissue with underlying choroid to the level of bare sclera is then done. Though Dr. Kuhn does not advocate it, but you can give 1 to 2 rows of prophylactic laser around the site. And any bleeding which happens during this removal can be controlled by either by diathermy or by increasing the pressure, infusion pressure. To understand the concept of chorioretinectomy, let me show you this case of a 28 years male with a double perforating injury in right eye. He also had endophthalmitis this eye. So we started this case. There was a cataract. We did a lensectomy. We cleared the anterior segment of anterior chamber of all the fibrous tissue and the blood. Then we sutured this wound. So this was the entry wound. We proceeded with the vitrectomy. We removed the vitreous hemorrhage. We cleared the exudates. And this was the exit wound. Because the patient was having endophthalmitis, we did not do anything to the exit wound at this point of time. But 2 months post-operatively, the patient presented with thick fibrous growth from the exit wound, which was extending to the fovea. And the patient's best corrected vision was counting fingers 1 meter only. So this was the time when we went inside. We removed the epiretinal membrane. We peeled off this epiretinal membrane. This was growing from this exit wound. Now we trimmed it. And to prevent again the recurrence, we now decided to do a chorioretinectomy. So 100% deep diathermy burns were given around this exit wound site. And then the chorioretinectomy was done, sparing the major retinal vessels. You have to spare the major retinal vessels, otherwise we'll end up in a lot of problems. So the choroid was either removed either by the vitrectomy cutter or it was just melted away by the diathermy. So you see, I'm using diathermy just to melt away this choroidal tissue. The uvate tissue was done away with it. So after we finished the removal of the choroid, we just did a fluid air exchange and left the eye like that. And this is post-operative, 20 days post-operative, the patient's vision improved to 624. 2 months post-operative, though there was some kind of element of vascular occlusion there, but the vision improved further to 6/18. And this patient, after 1 year, also you see there is no recurrence. The patient is maintaining a vision of 6/18 in this eye. So this is my second case. It's a 24 years male, hammer and chisel injury. So I'll show these cases. I'm showing where chorioretinectomy was inevitable. We had to do it. So in this, there was this thick fibrous band, which was from the retina extending towards the periphery. And there was a foreign body, which was detected on the preoperative X-ray and a CT scan, and it was lying in the coats of the eye. So after completing the vitrectomy, we tried to remove this fibrous band, but it was very difficult. So we plan to do a chorioretinectomy along this whole incarcerated tissue. So a large chorioretinectomy was done. You see, I'm giving 100% diathermy burns around this wound site. And then after this, the choroid was eaten up with the vitrectomy cutter along with the fibrous tissue and the overlying retina. So once this chorioretinectomy was done, we felt there is something below the choroid. Actually the foreign body was lying in the suprachoroidal space. So this was the foreign body, and then this foreign body was freed from the space and then was removed. So for the removal, we made an extra port, we put a chandelier, then we did a sclerotomy, which was around 2.5 millimeters, and lifted the foreign body with active suction, passed it onto the claw forceps, and removed the foreign body. This patient, we did a silicone oil tamponade. After this, so a fluid air exchange was done. You have to keep in mind, we have to keep the fluid air exchange at very low pressure, because there is a real risk of an air embolism through these open choroidal vessels. And you have to give a deep diathermy burns around this. That is very important in these times. So this is 6 weeks post-operative. The patient had, because the macula was fine, patient had a good vision of 6/12. Further, he underwent silicone oil removal after this, but unfortunately, I don't have the pictures right now. So this was another. Now I'm going. So this is another case where again the chorioretinectomy was done for the rescue. But this was a wire which was embedded in the coats of the eye. You see that this wire was so fixed in the eye that we tried to pull it out, but it could not come. It was so embedded in the coats of the eye. You see the effort being made, but this wire was not coming out. So in this case, we thought like we'll just do a small chorioretinectomy where the wire is embedded. And we just started from the posterior end of this wire. We tried to free the posterior end, but again, it was not coming out. So we had to extend the chorioretinectomy all throughout where this wire was. And slowly removing the choroid and the retina, we reached the anterior end. So once the anterior end was made free, we pulled the anterior end out and it came out. The foreign body was pulled and was lifted again using active suction and was removed through the limbus. In this case, after doing a lensectomy, we had to remove this large foreign body through the limbus. And then an intraocular lens was implanted in the sulcus, the same sitting. Again, the macula was healthy in this eye and the patient gained good vision of 6/6 in this eye. And you see the chorioretinectomy scar in the periphery. This is the last case which I'm going to show you where chorioretinectomy again was inevitable. It was a 20-year female known case of recurrent uveitis, underwent posterior septenal triamcinolone, but complained of decrease of vision after this injection. She came to me 1 week later, and you can see the entry wound in the of the needle which had perforated the eye. There was triamcinolone lying there, so we completed the vitrectomy. So there was an entry wound as well as there was an exit wound also. So the needle has traveled from anteriorly and hit the posterior part of the eye as well. So we removed this. This was only 1 week later, and see how much PVR she had developed. There was thick membrane which was overlying the retina in this eye. So slowly these membranes were lifted and pulled. And from the exit wound, you can see it was really difficult to separate it from the retina. So we had to cut it out. And then we did an ILM peeling. In this eye, the chorioretinectomy was done both in the entry wound as well as in the exit wound. So deep 100% diathermy burns around this exit wound, and then cutter was used to remove the choroid and the overlying retina. Again, see, I'm using diathermy to melt away whatever the uveal tissue has been left in this area. So this is 6 months post-operative. Patient presented 6 months post-op follow-up, and the patient's vision had improved to 6/18 on this side. So take-home message is that chorioretinectomy is a relatively a new procedure. It may prevent exit site wound-related PVR and fibrous growth over the retina from the wound site. It may be considered as a prophylactic or therapeutic option. I thank Weber for giving me a chance to participate in this session. Thank you.
Thanks a lot, Sangeet sir, for the wonderful videos, and you are truly doing incredible work. And hope we all learn a thing or two today from your lecture. Now, if any questions from anyone, any doubts?
Can I ask a question?
Please, sir.
Hello, Dr. Sandeep. Hello, sir.
Hi.
Sir, I wanted to ask you, besides a foreign body being stuck under the retina, what are the other indications that you choose to perform a chorioretinectomy, and how do you choose which cases you're going to do a chorioretinectomy, and how large the size of the chorioretinectomy you require? How do you decide that? When to do it and the size?
So I tend to do a chorioretinectomy for the foreign bodies, as you said, which are embedded in the actually penetrated the choroid, or injured the choroid at least, right? Or you can do it in any other trauma, like the last case I showed you. There was a needle which has perforated the eye. There was an entry wound and an exit wound also. And in those cases, there was, you see, within a week, the amount of PVR which has happened. So these wounds, they will, if you just remove the membrane, there will always be a recurrence of the epiretinal membranes forming again and again over the wound and leading to a decrease of vision. So in these cases again, and besides trauma, I have done chorioretinectomies for some ocular tumors like capillary hemangiomas, which are endophytic type of capillary hemangiomas, where the hemangioma is so adherent to the choroid, if you try to remove it, it does not come out on its own in those cases. And
there's severe PVR
around the incarceration site, trying to keep it as small as possible.
Okay. Thank you, sir.
Dr. Sangeet, have you tried chorioretinectomies in these rhegmatogenous RDs, those ones with grade C or D PVR and recurrent retinal detachments? Do they work as well in that?
Initially, I thought so. I did a few cases of giant retinal tear. I thought that just do a chorioretinectomy and it will prevent PVR in those cases, because there is a lot of RP, exposed RP in those eyes. But unfortunately, it did not work in those cases, and stopped doing it completely for those cases.
Thank you. Excellent presentation, sir. Excellent videos.
Thank you.
Do we have
a
any
question, please?
Yeah. Hi, Dr. Mariam. How are you?
Hi, Dr. Aditya. How are you? Thank you for your excellent presentation and videos. Please, I have a question. What is your tamponade way when you do chorioretinectomy?
So it depends on other situations also. Sometimes I do use gas. Sometimes, like in the one case, which there was a suprachoroidal foreign body. I was very, I thought there was large fibrosis. I thought it is again going to, whatever I do, it is, PVR is going to develop even after chorioretinectomy. I put on silicone oil. It just depends, like case to case, varies case to case. But I at
Okay.
least put a gas. I don't leave it with air.
Okay. And when we do chorioretinectomy, you did systematically ilenpilin?
Yes, again, depending on the case, like in the last case in which there was a needle perforation, there was a lot of PVR. I did do ILM peeling along with it.
Okay, thank you.
Can I have a question? Sorry. Sanjit,
Hi,
what is
Dr. Mathur.
hello? Your post-op treatment differs from the ones you usually do in foreign body surgery, pharmacological post-op treatment.
Pharmacological. I do give the steroids post-operatively for a few days, like 1 week. I give a heavy steroid dose, like for 1 week, about 60 milligram, 1 milligram per kilogram of body weight. And after that, I just taper them off. Not much of a difference. Like that.
Okay. No methotrexate?
No methotrexate. No.
Thank you.
If we don't have any further questions, thank you, Dr. Sangeet. Thank you so much for this enlightening talk. And we can move on to the next. We can move on to the next presentation.
Yeah, good evening, everyone. I would like to welcome our next speaker, Dr. Ahmed Roshdi, who is a lecturer of ophthalmology and vitreoretinal consultant at Tanta University, Egypt. He's also an alumnus of the same university, and he has done his retina research fellowship from Doheny Eye Institute. I don't know him personally, but I keep seeing his dramatic photographs on the vitreoretinal group platform on Facebook. So he always has like these snippets and spot diagnosis and spot management inputs on social media. So I'd like to welcome him for his talk. He'll be talking about trauma and his approach in different case scenarios. Over to you, Dr. Ahmed.
Thank you very much. Thank you for the kind introduction. It's an honor to present in this prestigious meeting. Can you see my screen now?
Yeah, it's visible.
Yeah, it's visible. It's visible.
Okay. Okay. So I'll go quickly through the most common cases of ocular trauma. So ocular trauma remains a leading cause of visual loss, most commonly affecting men. Patients usually are young, less than 30 years old, and the pattern of ocular trauma are variable depending on the social and demographic and geographic variations. So we'll start by contusion injury. We can have a subluxated or dislocated lens, a vitreous hemorrhage, retinal detachment, retinal dialysis, macular hole, choroidal rupture, and submacular hemorrhage. So this is a case of subluxated cataractus lens in a 40-year-old patient. I started by doing an anterior vitrectomy and an anzectomy by the vitreous cutter. And I'm now doing a many technique. First, I externalize the leading haptics through a lower paracentesis to avoid falling of the IOL because there was a sphincter rupture and the iris was atrophic, so the IOL can drop easily. Now I'm docking and trailing the leading haptic routinely. Then I will routinely do externalize also the other haptic, and I'm now doing a pupilloplasty to manage this rupture sphincter and the widely dilated pupil. Here docking the needle through 27 gauge needle, and then doing a single pass force through pupilloplasty at one side, then repeating the same maneuver on the other side. And at the end, ending with a good outcome. If you have a posterior dislocated lens, you can use a vitreous cutter if the lens is soft, or use a phragmatome if the lens is hard. It's important to remove the vitreous before you manage the lens to avoid any traction on the vitreous base. The other scenario with blunt trauma is a retinal detachment due to dialysis. This is an 11 years old patient with retinal detachment due to a lower temporal dialysis. So in these cases, I go for scleral buckle. In this case, I did a 287 tire and 240 band, and I did cry to the area of the dialysis, and I did not drain the subretinal fluid. And as we see, postoperatively, retina was attached. The other scenario with blunt trauma is submacular hemorrhage. This is a 10 years old patient with a submacular hemorrhage after severe blunt trauma. I started by doing a core vitrectomy and detaching the posterior hyaloid. And surprisingly, you can see here that the posterior hyaloid was easily detached using just a flute needle. Maybe it was partially detached due to the severe blunt trauma. And here in these traumatic cases, it's very essential to indent and look very carefully in the periphery and search for any breaks that might have happened due to the trauma. And here you can see there is an upper temporal break. Now I'm removing the vitreous over the break and doing laser to the break. Then I will inject subretinal TBA. Here I'm injecting a subretinal TBA, and I did not inject subretinal air in this case because I thought that the hemorrhage was not very extensive, so I thought only the subretinal TBA will be sufficient. And as we see here, postoperatively, all the hemorrhage was gone by 2 weeks, and we can see here that the photoreceptors were intact, and this is the beauty of the subretinal TBA injection. So if we leave this case to resolve spontaneously, let's say, it will end in distracted photoreceptors and distracted macula. But if we intervene early and inject subretinal TBA, we can save the macula and save the photoreceptors. And here you can notice the area of the choroidal eruption that was hidden below the submacular hemorrhage, and essential to follow up this patient carefully because there is a risk of CNV growing from this area of the choroidal eruption. With severe blunt trauma, we can have also retinal detachment. Here's the patient that he has a history of previous severe blunt trauma that ended in a scar in the macula. Then he had another trauma that led to retinal detachment. Here we can see a giant retinal tear. And it's very essential in these cases with trauma to stain with Stryme syndrome because many cases does not have a BVD. Even we in the classic teachings that the giant tear usually have a BVD with trauma. I operated many cases with trauma that did not have any BVD. So after using the Thanos scraper to elevate the posterior hyaloid, I injected BFCL to the posterior ball to stabilize the retina. Then I will continue the BVD induction using the serrated forceps and the vitreous cutter. With penetrating injury, sharp instruments might penetrate the ocular wall, such as glass bottles or knife, or other situations such as working with a screwdriver. And interocular foreign bodies are common in war, rotothrastic accident, and striking metal on metal, such as hammering. And interocular foreign body, of course, need removal to avoid urgent removal to avoid siderosal bulbi, like in this case. With penetrating trauma, here is a case of penetrating trauma that was repaired 1 week prior to this surgery for repair of severe laceration of the cornea and the sclera. And we can see here a very dense hyphema that was very clotted and mixed with the ruptured lens. Here I was able only to make an opening with an NVR, then making another widens open with the cutter. I found a giant retinal tear, then I found a subretinal proliferation. Here I'm removing the subretinal proliferation. I found also a full thickness macular hole. I did a multiple inverted flaps for closure of the macular hole, and then routinely completing the surgery by removing the anterior flap of the giant retinal tear, doing extensive vitreous base shaving and laser and silicone oil. For interocular foreign bodies, you should have in multiple techniques and multiple tools for removing the interocular foreign bodies. One of these techniques is the iris shelf technique. So within the iris shelf technique, I remove the lens. Usually it's cataractus in most of the cases. Then I am now fashioning a posterior capsulexis by the cutter. Now I'm holding the foreign body with the vacuum of the cutter. I usually use a high vacuum, like 600, and I elevate the infusion pressure to avoid hypotony. Then I place the foreign body over the iris. And after placing the foreign body over the iris, I inject viscoelastic. And at this moment, I turn off the infusion and get the foreign body either with the magnet or the forceps. And after extracting the foreign body, I implant the 3-piece IOL into the ciliary sulcus. And if you have an intact capsule rhexis, do a posterior optic capture to ensure long-term stability of the IOL. So here I injected the IOL in the sulcus. And now I'm doing the posterior optic capture. You can also do the same technique with the forceps. Here I'm holding the foreign body with the forceps, getting it again over the iris and getting it out through the corneal incision. Here I removed the lens. I did a lens removal. Then I was planning to do the same technique. So now I puncture the posterior capsule with a 27 gauge needle. Here I'm doing a posterior capsule rhexis. Here you can see the anterior and the posterior capsule rhexis, and in this case the foreign body was very large. I held it with a magnet and I delivered it in the anterior chamber over the iris. Then I get it out through the corneal incision, and then IOL into the capsular bag. With cases with foreign body, you might have endophthalmitis like this case. Here we can see the foreign body is impacted inside a dense amalgamation of exudation due to the presence of endophthalmitis. Now I'm doing an opening with the vitreous cutter in the anterior capsule, and I am now again holding the foreign body with the vacuum of the cutter and getting it out into the anterior chamber. Then getting it out from the corneal incision by the magnet. Then I went back trying to clean the exudation over the macular area as much as I can, and cleaning this dense amalgamation of exudation that was the site of the impaction of the foreign body. And there was a lower retina detachment, so I was doing this very carefully to avoid more damage to the underlying detached retina, and air fluid and laser and silicone oil. This is another case of foreign body with endophthalmitis. I started by cleaning the exudation behind the lens, trying to avoid injury to the lens because I was planning to get the foreign body through the scalar route. Here I'm holding the foreign body with the forceps and getting it out through the scleral incision. This case of intraocular foreign body was associated with submacular hemorrhage. So after delivering the foreign body to the anterior segment and getting it out, I decided to inject a subretinal TBA. Here I'm injecting the subretinal TBA. And implanting the IOL into the sulcus. This is a case of flash intraocular foreign body with endophthalmitis. So he was operated 2 weeks prior for repairing of the scleral wound, but he has lash inside the vitreous cavity. Now I'm doing a core vitrectomy and removing the vitreous surrounding this lash, and just by aligning the lash with the cutter and just with vacuum, I aspirated the lash out through the port of the cutter. So after finishing the posterior segment work, if you need to work on the anterior segment, like to implant in the IOL or to do anterior segment reconstruction, I usually leave the eye for a few months before I work on the anterior segment. So like in this case was operated 3 or 4 months prior for lensectomy and vitrectomy for vitreous hemorrhage. Now it's the time for implanting an IOL using the Yamani technique, routine Yamani technique. This is another case that had iridodialysis and rupture sphincter. After implanting the IOL again with the Yamani technique, I will create an Hoffman bucket for repairing the area of the iridodialysis. Through the bucket, you pass the double-armed needle by docking it through the 27 gauge needle. And then you externalize the thread through the pocket and repair the dialysis area. And now I'm also repairing the rupture sphincter by doing papilloplasty. This is the last case that had a severe iris trauma and aphakia after repair of this corneoscleral laceration and lensectomy and anterior vitrectomy for a cataractus lens with ruptured anterior capsule. Here the iris was severely damaged and atrophic and fibrotic. So I'm trying to retrieve the atrophic fibrotic iris from the periphery as much as I can. I'm doing gentle stretch. Here I'm again doing this gentle stretch in multiple locations, trying to get maximum amount of iris so I can reconstruct this severely damaged iris. Now I'm creating an Hoffman pocket so I can resuture the root of the iris to the sclera. Again, the routine technique by using the double-armed 10O Brulin. I externalize the two needles through the pocket, and now I'm doing the pupilloplasty. And after tightening the pupilloplasty suture, I will tighten the suture for repairing of the iridolis. And now I'm implanting the IOL again using the Mani technique. And it's very essential to check for the presence of any vitreous that might have relapsed. So I injected triamcinolone, and here I found a small lack of vitreous through the main incision that was removed with the vitreous cutter. Thank you very much.
Thank you, Dr. Ahmed, for your nice bouquet of cases. Now, I would like to ask anyone in the panel if you have any questions for Dr. Ahmed regarding any of his cases or any other queries with regards to management of trauma.
Hello, Dr. Ahmed. This is Apoorv here. Hello. I just wanted to ask you about the technique that you use for subretinal injection of TPA. Are you using subretinal TPA in all cases of large submacular hemorrhage? And what is the needle and cannula that you use and your technique for injection of subretinal TPA?
Okay, so usually I inject subretinal TPA if the hemorrhage is thick and occupying a large area of the macula. I use a 41 gauge needle made by Mid1. I have no financial interest, and I connect it to again, there is an infusion. There is a special syringe for the subretinal injection of TPA. You can attach it to the usual injection system of the Constellation machine, and then I adjust the pressure to be like between 10 and 15 psi. And before I go inside the eye, I test the infusion. I test the pressure. I should have like a fast dribbling of the fluid, not have a jet stream. So if you have a jet stream of the TPA, then it is too much pressure. So you adjust the pressure between 10 and 15 till you have just a fast dribbling of the fluid. I usually go to the edge of the submacular hemorrhage and inject very slowly. And the aim to detach the whole retina around the area of the submacular hemorrhage.
Thank you. And there's no need to laser that break, is it?
Because
it's a very small.
Yes. No, it's very small.
Yes.
It's very small. No need to laser it at all.
Okay.
So we sometimes do have an issue here in India, especially in smaller cities, to find the 41 gauge cannula. So there have been certain like innovative modifications done for injection of subretinal TPA using the long 26 gauge needle also, and bent like a cystitome at the end. So it gives the length to reach the posterior polar, and as well it's not very wide bore, so to say, because the 30 gauge needle which we get here is very short. So the 26 gauge needle, a long one with the bent tip, that has been published from Shankara. So they have published a series of cases of submacular hemorrhage. They have used this modification in the absence of the 41 gauge needle.
But then the bore of the needle, if let's say if the bore of the needle, part of it be below the retina and part of it in the vitreous cavity, you might not have enough pressure so you can inject in subretinal space.
Yeah, I mean, I have not personally used it, but I've seen seen on like a series of videos of this particular modification, because sometimes we do have an issue here of getting this particular needle from the vendors, the 41 gauge needle I'm talking about.
Thank you.
Any other questions, or we'll move on to the next talk? I would request Dr. Apoor to introduce the next speaker.
Yeah, it's my pleasure to introduce the next speaker, Dr. Abdullahi Mariam from Morocco. She's the professor of ophthalmology at the Faculty of Medicine and of Pharmacy and Dental Medicine in Morocco. And she'll be talking to us about, she'll be providing us some further tips on the management of intraocular foreign body. Over to you, ma'am. Looking forward to your talk.
Hi, everyone. I try to share my screen.
Yes, it's visible now.
It's visible now? It's okay? You see my screen?
Yes, able to see your screen. Yes.
Hi, everyone.
Hello.
Thank you for the invitation. Our presentation is about types on management of intraocular foreign body. I think it's already done by my friend, Dr. Rushdie. Intraocular foreign body is ophthalmic hemorrhage which can result in blindness. It represents more than a third of open globe injury. Young man, metallic foreign body during hammering activity are the most common circumstances of injury, and intraocular foreign bodies were most commonly located in the posterior segments. The challenge of the surgery is to extract the foreign body without creating further damage. This surgical difficulty explains the diversity of instruments available to extract intraocular foreign bodies. The best forceps is one that has grip without breaking, without the risk of slipping or injuring retina when grasping. As you know, there are two ways to extract intraocular foreign body: the anterior route through a corneal incision and the posterior route through the pars plana or scleral incision. For the anterior route, the most frequent step in the surgery is the retrieval of the intraocular foreign body from the posterior segment into the anterior chamber, the anterior chamber. The intraocular foreign body may slip from the intraocular forceps or magnets, will change in hand, or there may be resistance at the corneal incision. To overcome this difficulty, many techniques describe it, like using either the iris capsule or the IOL support for the foreign body in the anterior chamber. The IOL is either placed before retrieval of the foreign body from the posterior segment into anterior segment. This is the lens blocking technique, or IOL is placed after transferring the intraocular foreign body to the anterior chamber. This is the lens scaffold technique. In the handshake technique, one hand passes to the other hand. In the anterior, passes the intraocular foreign body to other hand in the anterior chamber. We will try to show you all this technique in the following videos. Case number one. It was a 9-year-old child with the trauma of his right eye during hammering activity, with corneal wound sutured 20 days ago, with clear lens. Visual acuity was 0.3, with fundus was visible, vitreous hemorrhage, and the retina was attached. We see the clearance here. We start with the anterior vitrectomy, posterior central vitrectomy, which we induce a PVD, and we perform posterior vitrectomy. We are freeing the intraocular foreign body from its attachment. We inject a cohesive viscoelastic to protect posterior pole, and we perform scleral incision. And with forceps, we try to extract the foreign body through the scleral incision, but it didn't work in the first time. The foreign body moved next to macula. We mobilized away to the center of the macula. This, excuse me. We try to mobilize it away from the center of the macula. This movement is controlled. Why? Because the viscoelastic supported and separated from the retina. We mobilize it and we grasp it and we try to extract it from the through the scleral incision. We suture the scleral incision and we complete the vitrectomy. Case number 2 was a 51-year-old man, right eye trauma for 20 days ago during Hamlin activity. Visual acuity was limited to hand movement with endophthalmitis and cataracts. We start the surgery with standard posterior and anterior vitrectomy. The PVD was already done, and we are freeing the foreign body from its vitreous attachment and its fibrous capsule. And with active aspiration of the vitrectomy, we transfer the foreign body from posterior segment to the anterior segment. It's the iris shelf technique. We deposit it on the surface on the iris. We enlarge the incision, corneal incision. We try to extract it through the corneal incision. It didn't work. We mobilize the foreign body with the anterior chamber, and we grasp it and we extract it through the corneal incision. Excuse me. The third case is the same, the same clinic presentation with endophthalmitis and cataract. We start with placing iris hooks to dilate the pupil, standard phacoemulsification with posterior capsulotomy, and we remove all the opacified anterior vitreous. The posterior capsulotomy should be greater than 4 millimeters. We use the PVD, and we perform a large central vitrectomy. We inject viscoelastic substance, and we should clean the pathway of the foreign body. With active aspiration of the vitrectomy, we transfer the foreign body from posterior segment to the anterior segment, but in this case, we use the anterior segment as a support. We enlarge the incision and we mobilize the foreign body with viscoelastic, and we extract it through the corneal incision. We place the 3-piece IOL in the sulcus with posterior optic capture, and we complete our vitrectomy. For the case number 4, it's the same clinic presentation, but in this case we have a retinal detachment, and the intraocular foreign body was larger with the measure set 7 millimeters. We start with traumatic cataract. We aspirate crystalline masses, and we complete aspiration with cutter. We add 2 hooks in the superior iris. We perform a large central vitrectomy, and we try to induce PVD. The posterior hyaloid was very adherent, and we inject PFCL to reapply the retina. We are frying the foreign body from all its vitreous attachments. and we remove one hooks to use this part of the iris as a support. We complete anterior vitrectomy and we enlarge the posterior capsulotomy because the foreign body was large. We transfer with cutter the foreign body from posterior segment to anterior segment. The lower part of the foreign body is supported by the anterior capsule, and the upper part with the iris. We enlarge the corneal incision, and we introduce micromanipulator with left hand to support foreign body to avoid its fall, and we extract foreign body from through corneal incision with forceps. We place a 3-piece IOL in the sulcus with posterior optic capture. For the next case number 5 was 33-year-old man, left eye trauma 2 days ago, visual acuity limited to hand movement with corneal wound and cataract without retinal detachment. In this case, we are going directly to the step of extracting intraocular foreign body. Here, I choose to remove an intraocular foreign body with forceps because the foreign body is embedded in the retina. So I remove it. So I remove it with forceps, and I transfer it from the posterior segment to the anterior chamber with the forceps, not with cutter in this case. And I deposit on the surface of the iris. Then I enlarge the corneal incision and I implant the 3-piece IOL in the sulcus very slowly to avoid to fall intraocular foreign body. The IOL creates a barrier to avoid its fall. We mobilize the foreign body to orient the long axis towards the corneal incision in the anterior chamber filled by cohesive viscoelastic substance. And we extract the foreign body with the forceps along his long axis through the corneal incision. For the last case was a 40-year-old man, right eye trauma when cutting a steel wire, visual acuity limited to counting finger, sclera wound at 11 o'clock, 3 mm from the lambus, with cataract and vitreous hemorrhage. In this ultrasound sonography and CT scan show the presence of a large and longitudinal of metallic density occupying almost length of the eye. And here is the surgery. We start with traumatic cataract surgery, posterior capsulotomy. Here we are, excuse me. Here we are cleaning the cavity, the vitreous cavity of hemorrhage. Excuse me. We are cleaning vitreous cavity, and here we inject viscoelastic to protect posterior part. We see the steel wire firmly planted in the sclera and the retina. We enlarge the corneal incision. We complete anterior vitrectomy, and we grasp the anterior end of the foreign body. We make a corneal counter incision, and the right hand passes the foreign body to the left hand, and we extract it from the sclera, the corneal incision. We complete the vitrectomy with peripheral vitrectomy, and we place a 3-piece intraocular foreign body in the sulcus with optic capture, air fluid exchange, and retinopexy. This is the follow-up of this case after 5 months. Best corrected visual acuity was 0.4 with a clear anterior segment. Retina was attached with epiretinal membrane. In conclusion, my tips in posterior segment intraocular foreign body surgery: the use of cohesive viscoelastic substance to protect the macula and to safely move the foreign body on the retina. The viscoelastic is is better than PFCL to support intraocular foreign body. Grasp the foreign body on a large surface. The use of the vitreous much as possible to transfer small intraocular foreign bodies from the posterior segment to the anterior chamber. In the presence of the surgical cataract, prefer extraction through the anterior approach because it allows better visual control at all times. It is less iatrogenic than scleral incision with more stable intraocular pressure and reduced surgical time. Thank you.
Thank you, Dr. Mariam, for the demonstration of a wide variety of cases and different surgical techniques. Yeah, I wanted to ask you if you have a clear lens with a foreign body, will you how do you decide whether you're going to sacrifice the lens and remove it through the anterior segment, or whether you're going to enlarge the sclerotomy and remove it through the sclerotomy?
If we have a clear lens with small intraocular foreign body, I remove it through scleral incision all the time. But if there is, I don't did in my experience a clear crystalline surgery for intraocular foreign body. But if there is some cataract, I prefer all the time to remove the intraocular foreign body through corneal or corneal incision.
Okay, thank you. Another question, whether you're using the magnet to hold the magnetic foreign bodies, are you using the intraocular magnet often or not so much?
I don't have a magnet.
Okay.
Yes,
okay.
It will be useful, sure, for
Okay.
sure, but I don't have an intraocular magnet.
Okay, thank you. Any other
Thank you.
questions? Any questions from anyone else in the panel?
Miriam, do you routinely use intravitreal antibiotics for intraocular foreign bodies post-surgery? Do you give to prevent endophthalmitis?
No. I didn't inject systematically antibiotic for all intraocular foreign body, but if it was endophthalmitis, yes, I did it in the end of surgery. But for all, no. For all cases, no.
And what about systemic antibiotics? Are you giving systemic antibiotics orally or intravenous in these patients?
I give a systemic prophylactic systemic antibiotics like another surgery, not something special for intraocular foreign body, you know?
Okay.
But if it isn't endophthalmitis, but if it is endophthalmitis, I inject before and at the end of the surgery.
And your take on perfluorocarbons versus cohesive viscoelastic for
Yes, it's a great point. In my experience, viscoelastic substance supports better and better than PFCL when the foreign body fall in the posterior cavity, and it separates when we have to mobilize the foreign body. The viscoelastic separate the foreign body from the retina, and it is secure to mobilize the foreign body. It's my experience. I prefer. I see some surgeon who did the experience in the cup And he used PFCL and viscoelastic, and he put on the foreign body, and we see a very huge difference between the two caps. And in my experience, I confirm these results.
Thank you, Dr. Mariam. Excellent presentation, excellent surgeries.
Thank
Any
you.
other questions do we have for Dr. Mariam? So, thank you, Dr. Mariam, and we would like to move on to the next talk. Dr. Ashish, can you please introduce the next speaker?
It's my pleasure to introduce our next speaker, Dr. Saad Wahib. He's a dynamic vitreoretina surgeon trained at the University of Toronto and is practicing at First Eye Clinic in Jeddah, Saudi Arabia, as the founder and director since 2016. Also, he heads the King Faisal Specialty Hospital and Research Center in Saudi Arabia since 2002, and he'll be discussing about traumatic macular holes in young patients. Over to you, sir.
I think we have Dr. Saad is not rightly with us. Probably he'll join us later. So we can move on to the next presentation. We have Dr. Marcelo Murillo Sasamoto from Bolivia with us. And he is an excellent dynamic vitreoretinal surgeon, the president of Bolivian Vitreoretinal Society as well. Dr. Marcelo, if you're ready, can we have your presentation?
Yes, for sure. Thank you very much for the invitation. I will share my screen. Okay.
Yes, sir, it's visible. Your screen's visible.
Okay. So this is a female patient who was the victim of an assault and blunt force trauma that led the lens dislocation to the posterior pole. This technique is a modified Yamane technique. We're going to publish this new technique called Yamane Sasamoto. Since, as you will see in the video, first of all, we use the entry of the trocar so that the optics come out. We do not create a scleral tunneling to bury the flange, the fungus flange of the distal part of the optic. We use a scleral graft and tissue glue to cover the optics so that they are not exposed over time as the structures of the eye thin. We saw how effective there is no certain stability of this type of techniques over time. So I will show you this new technique. We put the trocars to perform a small vitrectomy and then to present the optic through the trocar. Then, since we are levitating the intraocular lens, presenting the optic through the trocar incision, then we're performing the flange as Yamane technique, presenting the other optic. And then we start to put some glue, tissue glue, and then protecting it with scleral graft, covering with conjunctiva, one part and the other. Sometimes I use Vicryl 8 to close my conjunctival incision. and we finish the procedure. So it's a small video, but it's a very interesting technique. I would like your comments on that. And well, thank you. Any comments?
So Dr. Marcelo, are there any chances of that haptic dropping back or the IOL dislocating or tilting of the IOL, because you have not exteriorized into any scleral tunnel? You have just passed it through the trocar. It would like a vertical, that you just have taken out the haptic and just cauterize the ends. Do you feel it will stay? It will be a stable technique?
I believe it's a more stable technique since we have the scleral graft sustaining that optic. If you see all the glaucoma bulb patients with the tube in the late, I mean, 2-3 years after the surgery, the tube is totally covered and the scleral graft is part of the eye. So the same principles goes with this scleral graft through the optic. So there's no tilt. Actually, I have 3 patients doing this technique, and it's a one, but I mean, it's an option to what we are fearing in the future, to the tilt. I mean, 20 to 25 years, more or less, there's going to be erosion of all of that sutures and material, intraocular material also. So I think we could give a chance with this type of technique. It's a new one. I just got 3 cases, so we need more studies and more cases also.
You're very right. Do we have any other comments on this technique? Dr. Sangeet, would you like to comment? Any other comments? So that's an interesting technique, Dr. Marcelo, I think. But in this technique, I do feel the economics are gonna go up, especially with the scleral graft and the glue. But it's an interesting take. Probably we can have you again next time with a lot more cases and a detailed data for how the technique is doing, and probably it may turn out to be better than the original Yamane one.
Thank you very much.
So thank you, Dr. Marcelo, so for an interesting talk, and we hope to see you again with us next time as well. Do we have Dr. Saad Wahib with us? I don't think so. So thank you, everyone. So with this, I would like to wrap up this session of Pan Ophthalmologica Vitreoretinal Trauma Techniques. Thank you, Dr. Sangeet, Dr. Ahmed, Dr. Mariam, Dr. Saad, Dr. Marcelo, for taking out your valuable time and providing us great insights into your surgical techniques. And we have learned a lot, and every one of us is taking a few tips back for their own surgeries. Thank you. Any comments from anyone?
Thank you, everyone.
Thank you very much. Thank you.
Thank you.
Thank you.
Thank you. Bye.
Thank you. Then we should sign off. Thank you, everyone.